Hello and welcome everyone. My name is Amanda Varnakula Surya, and in this presentation I will be talking about the history of mental health and how it changed over the years. So to begin with, where does this consciousness come from? Well, obviously it came from an evolutionary process. So there's this whole subculture of people talking about this evolutionary psychology for all different kinds of traits, including the consciousness. And let's dive in how it all started. Well, evil spirits were popularly considered to be the source of mental illness during older days. To treat this, a mentally ill person would undergo trepanation, which entails drilling a hole in one's brain to release the evil spirit. In Stone Age, sharpened stones were used to perform trepanation. In North America, a gradual scraping of the skull in a circular manner was a common technique that was used in American tribes. The holes and skulls were mistaken for weapons and accidents in Europe, but because of the similarities, it was revealed that these were caused by trepanation. It seemed that they were the treatments of everything from migraines and epilepsy. Hippocrates, the father of medicine, was a famous Greek physician who was the first known chest surgeon as well as the first to propose the concept of mental sickness. His theory involved in imbalance of humors, where uh, which was defined as body fluids such as black bile, yellow bile, phlegm, and blood. He said that when the humerus was imbalanced, the patient's personality, the physical and the mental health would also be affected. This theory differed from the belief that people became ill because of it was the work of God, as was as in case in Greece, Egypt, and Mesopotamia. Asclepius was the first to distinguish between hallucination, illusion, and delusion. He stressed out the fact that the importance of environmental cases for mental illness and recommended more relaxing treatments opposed to bloodletting and restraints. Savanus was the one who suggested the treatment that would exercise the mind, such as having um, patient patients participating in discussions with philosophers to cure these fears. But Glenn, Glenn saw the importance of observation, and and he and his concept of psychiatric physiology, which was based on neurosystem. In addition, he saw the clinical symptoms of depression as sign of malfunctioning in the neurological structures. During these ages, the most widely believed philosophy during the Middle Ages were the soul governed by the body. This belief was influenced heavily by the religious influences of churches and led to the scientific findings from Greece and Rome being forgotten later. And for example, Nicholas, a scientific philosopher in Middle Ages, thought uh, thought that the demons were the cause of most mental illnesses, which was not uncommon theory at that age. Other than that, in demonic possessions, they thought that the witchcraft, hysteria, and stress were all caused by mental illness. For those treatments for the ill included exorcism, hearing mass, and drinking cold glass of water. So to try and make the demon uncomfortable, so it would leave the human's body. But this method did not actually work, and later on this procedure changed to that the higher class could afford doctors to come into their houses and treat the patient there and provide the families instructions on how to care for this affiliated family member. Unfortunately, mental illness had not been thoroughly researched as it is today, and most physicians did not know how to properly treat a patient. They would regularly use purges and medics and bleedings to treat patients. If the family didn't want to bear the baggage more, the individuals would be sent to a private house instead of an institution. But the poor and the sick were sent to one of two places, which was the bedlam or the streets. In bedlam, families and friends were in charge of bringing food and other essentials to keep the inmates alive, but also allowed visitors which had no relation to the patient inside to the asylum. This was done to raise hospital income. These visitors were often wealthy, educated, and well-bred, and this became incredibly popular during the holiday seasons. Well, asylums were very popular in Europe and United States. As the time, the asylums were beneficial to the communities until the definition of insanity was brought up in 19th century. It came to an inclusion that elders, epileptics, and those who are in families who couldn't help or support them to be together. These resulted in overcrowding of the newly integrated asylums to fill up with people who weren't mentally ill but a burden to the families. These asylums were initially a place for the mentally ill to live away from the prisons of hospitals and people zoos. It featured gardens in which patients were encouraged to walk around. They were offered 4 meals a day. They were encouraged to dress up and even had daily tasks they could complete, such as sewing, reading, gardening, or playing games even. Because of how well the patients were treated and their focus on mental therapy, 25% of the people that were ill for more than a year were cured, and also 75% of people that were ill for less than a year were also cured. This success of this had more and more asylums popped up in all over the countries like Europe and US. In 20th century, veterans were returning home from World War II received improved treatment methods, but the hospitalization of many individuals were followed by mass institutionalization. This caused problems as a result. Francis Gilbrook suggested eugenics was the best way to deal with mental ill in order to keep them from reproducing, but after his theory lost its popularity, outpatient clinics were the ones that became popular as they allowed patients to have freedom, but they can be also be treated when necessary. Unfortunately, many individuals became worse in this outpatient care, and mentally ill patients were often sterilized without consent or knowledge while they were placed in hospitals to prevent them from mating with normal people as an offer to try to create a better uppercut. Dr. Moniz, a Portuguese neurologist, carried out the first lobotomy and received Nobel Prize for his work in 1948 before the undesirable side effects were uh, being showed from the lobotomies, and then the product lost its popularity. The later on, Walter Freeman created what he thought to be a faster, a more efficient method called the ice pick lobotomy. His fake was driven beneath the eyelids of both eyes and had swelled around to scramble the neural connections. And these were the practices that were used before 21st century. But despite incredible advances in treatment and understanding the mentally ill, negative stigma associated with the mentally ill is still prevalent in this society. But more effective are institutionalizations are the more effective it is, the more effective our treatments can be, and then the better our society can function. And then this will benefit not just only the people who have mental illness also. So, who receive treatments? Well, unfortunately, many people who are suffering doesn't receive treatments, and there's a number of reasons why somebody who's suffering from a mental illness might not receive treatments. And so, the first reason that they might not recognize that they need treatment. Even they may have misconceptions about the mental health or about their symptoms, and so they may not realize that they need to seek help, or they might not understand the severity of their symptoms that they are suffering from, so that they may not be able to have the insight to into their own symptoms to recognize that this is something that they need to be get treated for. And even if they do recognize the need, and even if they are willing to and able to receive the help, but it doesn't necessarily mean that they'll get the treatment. And the part of this might have to do with the availability of the professionals in that area also. So they might be suffering from particular symptoms of a particular disorder, and they simply might not be people available to help them. And even if there are people around, and there's that person would be willing to receive and uh, willing to receive help, but there might not be uh, well informed about the options that are available. And to them, they might think, yes, I would like to get help if it was available, but think it is not an option for them, and doesn't know that what sort of options are available to them. And then even people who are willing to receive help and have professionals in their areas, they will inform of those options, even that not all of the people would get the necessary treatments. So this brings us to another barrier that can get into the way. One of it is stigmatization, and this can come from any number of places, but it could be their family's environment or their social group where there's stigma associated with certain mental illnesses. Uh, they can maybe pressure that one has to learn to deal with this with their own problems independently, and this stigmatization could reduce the chance that the person uh, that goes to get help. There also could be bureaucratic hurdles involved in preventing someone from getting treatments, and one might just be uh, put into a waiting list also. So the person might be willing to get the treatment and know about the options, but they might not have the treatment available for the person at that time. There's also financial difficulties that could get in the way of paying the treatments, and again, depending on the disorder, the person suffering from the type of treatment that they are seeking. So this cost could be also substantial, and the person simply might not be able to afford this, and this brings us to the possibility of insurance coverage being involved in. So people might have disorders that they need treatment for, but it might not be covered by the insurance, and this means that they might not actually seek out the treatments also, even though that it's fairly clear that they might need it, or they would benefit from it. And next, we also have linguistic and cultural barriers as well. They can also get in the way. So, people who might benefit greatly from something like psychotherapy, which is going to involve a very deep communication with another person, if there's not a therapist in their area who has the fluency in the language that the patient needs, then they might not be able to have the proper treatment. Or there could be cultural barriers where certain cultural view related to either stigmatization or what sort of treatments are acceptable for the patient, but those might not be available also. And it's also in the case that the best treatment might not be available. So for somebody might having a disorder that recognize they need treatment, but the best treatment uh, for the patient's particular disorder and that particular patient both might not be available at the same area also. So they might either settle for a less efficient treatment or decide that they doesn't want any treatment at all. So all of these can too be explained why it is that some people aren't getting treatment that they would be benefit from. And lastly, we can consider some of the ethics associated with the treatments. Usually, in the ideal world, everybody would have who has a illness would recognize the need to that and get treated. uh, they would then freely choose to get the best possible treatment for what they were suffering from. But that's the ideal world. Unfortunately, that's not how things really are, and there are cases where people either doesn't recognize the need or they choose not to get the treatment, and brings us to this ethical question of whether we can force people to get treatments. We already talked about this, how treatments is beneficial to not just to the people but to society in general. And so we should wonder, is it possible that we should be forcing certain people with certain disorders that they have to get certain treatments? And this brings us to the point that was brought up by Professor Thomas. He said that the myth of mental illness, which is the psychiatrics, aren't just the aren't just against of this illness. Ideally they would be, but they would always be on the side that the person who is suffering, and they are trying their best to help the person. But unfortunately, psychiatrists often have to act as an agent of others, and in some cases they might be in the family or friends of the person who is suffering, either because the person doesn't really uh, realize the treatment is available, or they are like they resist getting the treatment, and family and friends may try to force that person to try to get the psychiatric on their side to convince this person to get the proper treatment. Or psychiatric might need to act as an agent of another organization like law enforcement or court system, or for private organizations also. And that brings us to the next ethical issue, which is the role of private organizations in defining the mental illness, or in defining what sort of symptoms should be required treatments. And one of the main criticisms of the classification system like the DSM is that it can represent a medicalization of a daily life. And what that means is that sometimes some types of suffering might be seen in a normal aspect of a human condition also. So yet the DSM orders some of the possible disorders, and if you look into it, you'll see that there are certain things that are probably, and that you also probably experience also. Well, there are things that are disrespectful that would be fallen into the symptom categories in the DSM. Somewhat we might wonder whether these are things that are just normal part of life, or is that it's actually represented as an illness that therefore needed treatment. And if we were being critical of certain organizations like the pharmaceutical companies, we would be wondering how much they are pushing for the larger customer bases by expanding the definition of what mental illness is, or expanding what we see as a symptomatic of mental health issues, like rather than just saying those are just the difficulties of life, those are the problems of life. And one particular example for this is, if we look at the DSM-5, we see that the case of major depressive disorder, the bereavement exclusion used to be the case that in earlier editions of the DSM-5, that if you were suffering from a symptom of depression, but there were occurring after the loss of loved ones or some other type of bereavement, then your symptoms would be seen as a symptomatic of major depressive disorder. We'd say yes, you were suffering, and yes, you had depressed mood, but because it's in response to this life event that was caused of grief, therefore this means that you doesn't have major depression, even though you are actually suffering. But controversially, in the DSM-5, this bereavement was removed, and so now even if you are suffering the loss of loved ones one recently, and you go to a physician and they see this as a symptom of depression, now they can give you they could give you the diagnosis of major depressive disorder, and they means that you could then receive something like a antidepressant medication in order to help you cope with this symptom. And also, yes, people might wonder if it's medicating away the negative emotions, whether it is appropriate or whether they should suffer the negative emotions, whether it's okay to experience them despite the suffering we recognize, or is this a part of life and we might actually want this suffering? Maybe it tells us about the relationship with a person who was lost or something like that also. And so this brings us to the question, what kind of suffering should be treated and what kind should be just dealt with alone? um, what kinds are just a part of life and we shouldn't be trying to uh, chemically exercise them out of our brains and bodies. And then the question where who gets to decide that decide this, and how do we incorporate that into whether or not somebody should be getting treatment for some kinds of suffering that they've experienced or not. So of course, I don't have the answers for these ethical questions, and I'm raising them in this video just so y'all could think about it, and about the role of these possible ethical issues, and in how to determine who gets the treatment and when they get the treatment or why do they get the treatment, and so on and so forth. So that is it about this presentation, and here are the references that I've used, and I have linked them down in the description box below also. I hope you all found this presentation helpful, and if there's any questions, please do type out. I would gladly answer, and yeah, thank you.